Now you have 3 cases from the high resolution manometry and pH impedance studies. The first case will be presented by Professor Ricardo Brandt, and probably with Gabriela Bueno, I think so.
Yes, I would like to take the liberty to introduce Gabriela Bueno. She's a medical resident in clinical gastroenterology at the Hospital das Clínicas de Ribeirão Preto, and she will present the case. Please, Gabriela.
Good morning.
Sorry, I want to introduce Professor Ricardo Brandt. Professor Ricardo is one of our mentors in our group in Fortaleza. He is full professor of gastroenterology in Faculdade de Medicina de Ribeirão Preto. It's a really a great pleasure to be you here, Professor. Go. Now you can go, Gabriela. Thank you very much for you.
Grateful for your kind words, Marcelo.
So good morning, everyone. First, I would like to thank Professor Ricardo for the opportunity, and thank you, Professor Sifrim and Professor Ghoshal for the brilliant presentation and the lecture. It's an honor. So now I'm going to share my screen, and you tell me if you can see the presentation.
Yeah, you can see.
Okay, can you hear me okay?
Yes.
Okay, so just like Marcelo said, my name is Gabriela Bueno, and I am a gastroenterology medical resident at Hospital das Clínicas of the School of Medicine of São Paulo University. And today I'm going to present a case of provocative impedance high-resolution manometry. So it's from a 46-year-old woman with an unremarkable medical history. She reported regurgitations without hatching or gagging over the preceding 6 months. The regurgitations typically began within 15 minutes of eating and would last for about 1.5 hours after nearly every meal. The episodes of regurgitation first included regurgitation of recognizable food material, but the regurgitations tasted more acidic as the episode progressed. She did not notice foods that increased regurgitation frequency, but in a few occasions, she experienced regurgitation of recent ingested pills. She reported heartburn and epigastric pain and a 9-kilogram weight loss in recent months. She repeatedly denied dysphagia, purposefully restrict food intake, or binging and purging behaviors. Her physical examination was unremarkable, and upper GI endoscopy was normal. So here we're going to start with the first high-resolution manometry frame. So this was a single swallows in the sitting position. And first we can see the low resting pressure on the esophageal gastric junction, but with an adequate relaxation after the wet swallows. Now, looking at the esophageal body response, we can say that the peristalsis is almost absent, with a really low peristaltic amplitude. And so the DCI in the medium of 10 swallows was 28 millimeters of mercury per centimeter per second, which is really below the normal value. And the IRP in the medium of 20 swallows was 9.3, which is within the normal value, but in the lower range. in sequence, in the next frame, this is the multiple rapid swallows test in the sitting position as well. And we can now see here that there is peristalsis with high peristaltic amplitude following the multiple swallows test. We can also see some stomach contractions and the presence of gas in the esophagus. On this next frame, we can observe an spontaneous, non-externally driven upper GI motor activity, which was recorded nearly 5 minutes after test meal completion. And now we can see this typical rumination syndrome manometric pattern, which shows a gastric strain, the common cavity phenomenon, and in the impedance, we can observe retrograde esophageal fluid flow and the upper esophageal sphincter relaxation. So here we can see an overlay of the manometry and the impedance image. Again, spontaneous and non-externally driven motor activity. So we can see the retrograde fluid flow concomitant with the upper esophagus sphincter relaxation and the gastric contractions. In this frame, we can observe that the episodes were recurring. So this was nearly 10 minutes after test meal completion. And on this frame, we just wanted to later discuss about the presence of a stomach contraction concomitant with the presence of gas in the esophagus, preceding the event of the rumination. And here is the video of the 3D model of the esophageal manometry showing the gastric strain and esophageal contraction. So now we're going to talk a little bit about the case outcome. So this patient was submitted to the following treatments. She was put in some behavioral therapy via diaphragmatic breathing, and we observed poor adherence to the treatment, leading to poor results. We tried as well the baclofen 3 milligrams, 10 milligrams 3 times daily, which we observed no clinical improvement, the persistent ruminating symptoms, and severe adverse effects such as drowsiness and dizziness. The patient was kept on proton pump inhibitors with the improvement of pyrosis. So now we're going to bring some questions to later discussion. The first one is there an association between the hypocontractility in the esophageal body, as we can see on this picture, and the rumination syndrome that the patient presented? Just to remember the audience that the DCI was really below the normal value. The second question for a discussion is the peristaltic contractions following the multiple rapid swallows were more vigorous in those following the single swallows, and if this could indicate a positive response to prokinetics in the present case. So Here I brought a discussion for the variants of the rumination syndrome suggested in the Kessing et al. So the primary rumination is the abdominal pressure increase, resulting in the retrograde flow of gastric content, which is the most common mechanism of rumination syndrome. The secondary rumination, we can see the increase in the abdominal pressure that occurred after an onset of a reflux event. And the third one is the supragastric belch associated rumination, which we can see that the abdominal pressure the increase occurred during the expulsion of air and preceded the retrograde flow of gastric contact. So the next question is, what variant of rumination syndrome are we dealing with in this case, in the present case? And the last one is, what is the next step for the treatment of this patient? And that my presentation ends here, and I would like to give the word to Professor Ricardo if he wants to discuss a little bit.
Thank you, Gabriela, for the case. I would like to know if Daniel could comment this case.
I will try to answer the questions first. The first question concerning the hypomotility in the esophageal body, in my mind, can be due to two possible reasons. One is that the patient has a universal hypomotility, not only in the esophagus, but also in the stomach with delayed gastric emptying and perhaps even in the intestine. So one thing that I suggest to do is to measure gastric emptying times and see if she has a severe gastroparesis together with esophageal body hypomotility. Because if this is the case, this is more than an idiopathic rumination, but it can be a patient with a pan-GI hypomotility. The other possibility is, and this is related to the second question, is that I couldn't see the type of air movement before the rumination event, but the way you present it suggests me that it might be supragastric belching preceding the rumination. And if this is the case, the hypomotility in the esophageal body is very commonly observed in patients with supragastric belching. The reason, I don't know. My hypothesis is that the esophagus is distended chronically by air, and it works like the right ventricle in the heart, which is distended, and has a hypomotility. I don't think that the muscle is damaged because post-MRS, the after contraction is good. So I think that this is more a functional hypomotility, and it can be secondary to continuous presence of air. So if this is the case and the rumination is supragastric belching related, the target is the supragastric belching. And the CBT is different than only rumination with diaphragmatic breathing. It's a little bit more complicated. So I think that the two questions need to be solved: whether there is a pan hypomotility, and two, whether this is supragastric belching related, and that needs to be treated a little bit different with a mouth opening, tongue behind the teeth, a part of the abdominal breathing. Final comment is the prognostic value of the after contraction present for use of prokinetics. We have studied this and unfortunately never managed to complete it and publish it. But we had preliminary data showing a response to azithromycin, who is a macrolide antibiotic that has a similar effect to erythromycin, both on gastric emptying and esophageal contractions. So the patients that had what we call now good peristaltic reserve, an adequate contraction post-MRS, were those that responded better to azithromycin. So these are the three questions that you propose, and I discussed them all. I suggest to try a macrolide antibiotic, the one that you have available. I suggest to look at supragastric belching before the rumination, and if it is present, do the proper CBT relative to that. And the worst case scenario is that she has one of these pan-hypomotilities. And if you ask me how to treat it, my answer is, I don't know.
Okay, thank you.
Yes, Professor Ricardo, do you want to comment?
Unmute. Ricardo, you need to unmute.
Sorry. Thank you very much, Daniel. I was unable to answer the questions Gabrielle had put for me. So I'm very grateful to you for doing so. Thanks.